Hi, my name is Tyler Owens. I'm a student physical therapist assistant at Jeff State, and this is my presentation on mobility interventions in the ICU. So let's start with what is early mobilization. Early mobilization is the application and intensification of physical rehabilitation given to patients with critical illness, usually within the first 2 to 5 days of being admitted to the ICU. It includes activities such as in-bed mobility activities, range of motion exercises, sitting, standing, transfers, and gait training. Early mobilization is important because immobility impacts every functional system, including the musculoskeletal, cardiovascular, and respiratory system. Early mobilization prevents or reduces these effects and improves outcomes in patients following critical illness. Patients admitted to the ICU are generally confined to bed, which leads to limited mobility that may have detrimental effects on different body systems. Prolonged periods of immobility can lead to muscle atrophy and generalized weakness, pressure ulcers, decreased cardiac and respiratory function, loss of function, DVT, infection, and overall decreased quality of life. Some skilled interventions that we as PTAs can introduce are supine and side-lying activities, edge of bed activities, transfer activities, and gait training. Supine and side-lying activities may include active and passive range of motion, bed mobility, developmental sequence activities, P&F techniques, and active and resistive exercise. This video is demonstrating a developmental sequence activity called rhythmic initiation. It is in supine and starts with completely passive motion, works to active assistive motion, and then ends with resistive motion. Some edge of bed activities include active and resistive exercise, such as manual stretching, P&F techniques, and active and passive range of motion. Activities can also include challenging the static sitting balance, such as self-care tasks like combing hair, eating and drinking, and bathing and dressing, and also activities that challenge the dynamic sitting balance, such as reaching outside of the base of support, as shown here. Transfer activities can include sit-to-stand transfers, weight shifting with assistive devices, and pre-gait activities. Resistance can be applied to sit-to-stand transfers to help the patient weight shift more onto one side during the activity. Weight shifting with the assistive device, you can also apply resistance with this if they are having trouble weight shifting onto a particular side, or either that they are weight shifting too much to one particular side. With pre-gait activities, you can do a D1 flexion pattern using alternating isometrics and using the irradiation concept with the involved leg on the floor. With these activities, you do want to make sure that they have a gait belt on, you are guarding on the correct side, and they either have shoes on or grippy socks for this activity. Some gait activities we can utilize are standing balance, weight shifting, marching, and ambulation. With these activities, you want to teach the patient the correct gait pattern. You want to try to get them to be as compliant as they can be with weight-bearing status, giving verbal cues as needed. You also want to be mindful of any equipment that the patient has, and with that, the gait belt placement. You don't want to place the gait belt over any tubing or any lines that the patient may have. You also want to guard on the correct side. You can provide the appropriate level of assistance, and make sure the patient has on shoes or grippy socks for activities. Here are some equipment that you may typically find in an ICU. This can include different types of beds, EVA walkers, Lofstrom crutches, axillary crutches, rolling and standard walkers, canes, and even wheelchairs. It's a good idea to get acquainted with the equipment and knowing what it can and can't do in order to be able to be safe and properly use it for your patient. Barriers to early mobilization can include patient-related, institution-related, and clinician-related barriers such as limited time and staff, patient status, level of arousal, and medications the patient may be on, lines, tubes, drains, and devices that the patient may have on them, and what equipment, if any, is available for us to use. Some precautions and considerations are chart reviewing, so knowing what high and low values are for lab values and knowing how those values may affect your patient that day. Get familiar with your equipment so you know the limitations and capabilities of the equipment, and also so that you can teach a patient how to use that equipment. Know your surroundings, so know where emergency equipment is, know the codes, know who to call and where things are in case of emergencies. Have a plan when you walk into the room and be adaptable. You're going to have a treatment goal for the day, and you need to be able to pivot and get things done when things go awry or don't go your way. This has been my presentation on mobility interventions in the ICU. Thanks for watching.